Before I move on to the course itself, I'd like to invite my co-instructors, Dr. Praveen, who is a consultant at CFS on the dais, Dr. Kumar Ravi, he'll be joining us shortly, Dr. Silpi Agrawal, who is consultant at Lakshmi Netralaya at Patna and a trained glaucoma fellow, Dr. Manish Singh, director and faculty consultant at Netralayam, super specialty, also treasurer of the GSI, Dr. Mamta Singh, who's assistant professor at All India Institute of Medical Sciences, Rajkot. Dr. Ravi will be joining us. So let's move on to the course itself. So the primary objective of this course is to identify the mistakes and the reasons of the glaucoma failure and glaucoma treatment failure as well as diagnostic failures, and then build up our treatment protocol to for the betterment of the patient vision and the patient outcome, visual outcome. So glaucoma being the second leading cause for the blindness worldwide and in India also. And early diagnosis and treatment is essential to prevent the glaucoma and its accompanying loss. Slide is not moving. Excuse me. Yeah, it's moving now. So why failure is important? Because this is a chronic disorder. Usually failures are bound to happen, and identifying the failure at appropriate time is going to save the visual life of the patient. It is also distressing for the treating physician as well as the patient when failure occurs in the treatment or in the outcomes, whether it is diagnosis, medical laser treatment or surgical management. The failures are really hurting in these cases. The objective of this course is to make the attendees identify the reason of failure and way to fight in order to make the quality of the patient vision. So these are my co-instructor, and they'll be dealing over the medical management, laser procedures, surgical failures, and patient quality of life during the course of this talk. So coming to my talk, glaucoma is sneak thief of sight, no symptoms, very gradual loss of vision, no cure, only control is there. What Lancet has said in the recent article that glaucoma was the ranked second leading cause of the blindness and also the most common cause of irreversible blindness and the second most common cause of irreversible moderate to severe visual impairment. Estimated to be 27.8 million people by 2040 in Asia. India and China will share the maximum burden, equal proportion of the open angle and the closed angle glaucoma, responsible for 5.9% of blindness, and 90% of the glaucoma is undiagnosed. That's a huge number. So it is defined, so if we based our definition based on the visual acuity criteria instead of the visual field, which are definite criteria for glaucoma, every 8th individual of the nearly 40 million of the estimated 309 million population is it 40 or older in the India either has glaucoma or at the risk of developing the disease. So there are certain surveys available with us like APDIS, Andhra Pradesh Eye Disease Study, Arvinda Comprehensive Eye Survey, Vellore Eye Survey, and Chennai Glaucoma Survey, which throws some light on the actual prevalence of glaucoma and the findings prevailing in the society. So what Andhra Pradesh Eye Disease Study says, 11,786 subjects were enrolled, and what was the outcome? Outcome was definite POAG in 2.56%, suspected POAG in 1.1%, OST in 0.42%, and again 92.6% were undiagnosed. In PACG also 66.6% were undiagnosed at the time of survey itself. So you can very well comprehend what is happening in the community. Next study was Arvinda Comprehensive Eye Study. Again, 93% patients were previously undiagnosed and 2.6% was the glaucoma prevalence in these cases. In Vellore Eye Study, routine gonioscopy was incorporated into the survey tools, and that shows that once you incorporate gonioscopy into your tool, what is going to happen? The prevalence of PACG increases to 4.32%. So unsuspected high prevalence of primary angle closer glaucoma was present in the society. That means you have to incorporate gonioscopy in your routine practice. Now, the next study was Chennai glaucoma study, and patients who have undergone cataract surgery were at high risk, because these were the patients who were the patient enrolled were basically for glaucoma in cataract operated patients. So this is the summary of the different studies. The most important finding out of those surveys were undiagnosed, large volume of undiagnosed cases. Good number of angle closure diseases were present if you incorporate gonioscopy into your practice. Another study from this part of world, that Hooghly study was, total 14,000 patients were participated, and 2.7, this was having urban as well as rural arm, and 2.7% were detected to have glaucoma in the rural arm, whereas 3.23% in the urban arm. So significant number of POG had IOP within normal range. 90% of the POG and 70% of PACG were diagnosed during the survey. Prevalence of angle closure glaucoma was high. And then gonioscopy is essential in all the patients. So what are the critical challenges when we have to diagnose this large volume of the glaucoma patients? Since there is low level of awareness, undetected and undiagnosed cases, poor access to the glaucoma diagnostic and therapeutic services, and issues related to compliance with the treatment. So what should be the basis of a screening test? Mass screening we can do, but that's not possible in the volume which we have, the kind of population which we have. So selective screening and opportunistic screening are the two tools which we can employ for detecting these high number of undiagnosed cases. So the suspected cases are age more than 40 years, family history of glaucoma, diabetes, hypertension, steroid, colored halos, frequent changes of glasses, myopia and headache. These patients need to be evaluated. Having said that, all the patients coming to your OPD need to have a fundus, the disc evaluation done, as well as IOP evaluation done before we move on to the next level of evaluations. So every patient beyond 40 years need to have a screening for the glaucoma, and more so in cases of suspected patients. So which tests should be employed? Community level screening glaucoma is challenging task. To screen for glaucoma has no definite proven or even a consensus answer. So IOP can be one tool, but it's not possible. Short functional test of the different kind, like visual field estimations, is also not feasible for the community testing. Howsoever, the out-of-box screening tools now available with a shorter testing time, the disc analysis through a picture, the tools with artificial intelligence are available, which can sort out, which can actually pick up those unsuspected missing cases from the society, and that need to be used for the screening of the patients in the society as such. So primary level, we have to train the general practitioners and ophthalmic assistant, and the ophthalmic assistant need to be trained and need to be incorporated in this fight against glaucoma to identify maximum number of cases from the society. Secondary level is applanation tonometry, screening of family members and complicated cases has to be done. Tertiary level, we have to build up the capacity building has to be done. So to conclude, ignorance is not a bliss in glaucoma blindness. Opportunistic screening of all 40 plus patients attending IOPD need to be performed. IOP, gonioscopy, optic disc evaluation should be part of routine examination, and the tools which are available right now with artificial intelligence can be used in the society for screening at PSC level or CSC level or even at the basal levels, and glaucoma awareness campaign has to be performed. So with this, I come to conclusion of my talk. I'd like to invite now the next speaker, Dr. Praveen, who is a faculty and consultant at CFS Patna, a trained person from JIPMER, Pondicherry. He'll be talking on under and over diagnosis, a failure of machines or the man behind the machine.